if you were a person, if you were a caregiver to a person with cancer experience, if you were a patient advocacy group representative. We also put there journalist or media representative because why not? We hoped and thought maybe some policymakers and public health specialists would be interested in joining. We, of course, always welcome and need to include in our discussions healthcare professionals and academics and researchers. So this is what you see here, and you will see that this was purposefully a multiple choice exercise. We ask people to select as many roles that they represent. And you will see that there are a lot of people with lived experience who might also be caregivers, who are also representing patient advocacy groups or who are patient advocates themselves. Some of them might be healthcare professionals and some of them might be academics and researchers. And we see that there's a lot of intersectionality, and we will be talking about intersectionalities of identities later on as well. But maybe just one more slide to show you. At the registration, we have seen and we welcome registrations from people from 31 countries in total. And you will see that Romania and UK are the hotspots where we had more than 8 participants, actually, I think more than 10 participants from each of those. So welcome, everyone. Please feel free to use the Q&A in your Zoom function and your chat, and we will be taking questions later on. But let us go on and address the elephant in the room. So this is an unavoidable part of the introduction because we have all been very aware that President Trump has made lots of executive orders since coming into his term, but one of them was on cutting the EDI or DEI programs. EDI or DEI stands for Equity, Diversity and Inclusion. And obviously, it upsets a lot of people. The executive orders argument is that everything has to be meritocracy based, and that focusing on EDI or DEI, on equity, diversity, and inclusion policies may disadvantage other people. But our approach and why we argue this is that meritocracy is really about ability and effort, and understanding and acknowledging that success is the result of ability and effort. But we do believe that structural disadvantages do need to be focused on with EDI policies and programs in order to level the playing field. So we do believe in meritocracy with EDI policies in place, because this is the only way that everyone can have a fair chance to excel. And we have the same definition when we talk about equity in cancer care, where we believe that equity, true equity in cancer care, is striving for everyone to have the best chance of getting better. That means everyone. So we just want to make sure that everyone has the best chance. So this webinar, as we said, is in the context of several webinars that will be focusing on different aspects of diversity. And our first subject is neurodiversity. Now, this slide is from the Merriam-Webster dictionary. But there are 2 statements. One is a definition. Neurodiversity is referring to individual differences in brain functioning regarded as normal variations within the human population. And the second one reinforces the concept that differences in brain functions within our human populations are normal, and that brain functioning that is not neurotypical should not be stigmatized. And I have another slide about this too, if you find this a little bit too medicalized. And I do like this clear summary as well, that neurodivergent or neurodivergent individuals or neurodivergence these terms refer to those whose neurocognitive functioning diverges from dominant societal norms in multiple ways. And that this definition should not be used to exclude people, but rather to include them. There's a reference to this paper being published in 2021, but these concepts were first described in a very explicit way by Cassian Asasumasu, who is identifying as an autistic individual, an autistic person, and the concept of focusing neurodiversity as a broad spectrum really did come from the autistic community and people with autism. They were the first ones to describe it, and it has become a movement. Now, in literature, you will see varying conversations on what is included in neurodiversity as a terminology. And I prepared these 3 slides just as a background, because even as they were preparing this webinar, we had several conversations with panelists and with those working in the EDI work package of the European Youth Cancer Network project. So this is the most agreed upon consensus. So conditions that are broadly recognized as part of neurodiversity, as they involve lifelong neurodevelopmental differences in cognition, learning, motor function, and sensory processing, might be the autism spectrum. And here examples would be autism or Asperger's, as they were referred to. Nowadays, the preferred definition or naming would be ASD, autism spectrum disorder. Or attention and executive function, for example, attention deficit hyperactive disorder, so ADHD or ADD. Learning differences, as in dyslexia, dyscalculia, dysgraphia, dysnomia, or development speech disorders, or motor and coordination differences, such as dyspraxia or Tourette syndrome, or sensory and cognitive processing, sensory processing disorders, or synesthesia. Now, what we don't like a lot of times about these coins, that a lot of them come with the adage of it being a disorder, and any coining or naming of such conditions inevitably lead to stigmatization. A debated but often included conditions could be obsessive and compulsive disorder, or bipolar disorder, or schizophrenia and schizoaffective disorders. But some argue that they fit better under mental health and psychiatric categories. So some don't include this under neurodiversity. And the most controversial ones would be what would be considered personality disorders. So differences in emotional regulation or social interactions and self-perception, antisocial personality disorder, borderline personality disorder, etc. And some mood disorders, conditions that affect mood regulation, sometimes lifelong, but often episodic. And I know that we talked about this as well, because we had this extensive conversation of what happens to people, for example, with eating disorders and other conditions that we do know 100% affect their engagement with the healthcare system and their cancer experience, from diagnosis to cancer treatment, staying in the hospital, dealing with side effects, etc., etc. So obviously we understand that this is a very, very wide conversation, but for the purposes of today's webinar, we will really focus maybe on conditions that fall under these broadly recognized conditions and neurodevelopment differences in cognition, learning, motor functioning, or sensory processing. And here the word really is processing, like how an individual processes information and how do they engage with information that's given to them or with people around them or things around them and environments around them. And very specifically with cancer care that is provided or is accessible to them, or less accessible to them because of some of the mitigating conditions. And before we go deeper into the conversation, we also wanted to address why language matters. And I would like to apologize upfront that I will be stumbling through words and might say things the wrong way. And this is because, first, some of the language is underdeveloped or we're not that accustomed to it. Second, because we do need to learn about different groups' preferences, different people's preferences, and also because it just reflects that maybe this is not an area where I have a lot of learning behind me, or that I know so much about. So I ask for everyone's forgiveness if I don't say things correctly. And I believe that I speak for every single presenter who will be sharing their stories today, that we might be expressing things in a certain way that might not be your preferred expression, but we hope that nobody will take offense, because whatever we will be speaking about today and talking about today is coming from a really good place of wanting to have a conversation, wanting to have discussion. It comes from a place of curiosity and acknowledgement for everyone's different experiences. So I hope that it will be a nice experience for all our panelists today and also for all of you in the audience. And then just maybe address that our two main ways of expression and two schools of thoughts on language, on neurodiversity, and not just neurodiversity, but other identities as well. And for lack of better explanation, we have these two categories described as identity first language or person first language. Identity first language really refers to, or really refers to language that is sort of also the language of advocacy, maybe, that showcases self-determination and visibility, doesn't mind what we might coin as labels, because really advocates for diversity being natural and not a deficit. So it's being bold and visible about it. So some people might refer to themselves as autistic individuals or disabled individuals, for example. And another language would be a person first language. And here we would say that they are a person with autism, a person with neurodiversity, or a person with visible or invisible disabilities. And this first person language is preferred by some because they feel that it's reducing stigma and medicalization, and it celebrates the person before any label. And within Youth Cancer Europe very specifically, and this is where I'm coming from, and some of the speakers are coming from as well, we have found that this first person language supports autonomy and a broader self-definition, where individuals are recognized for who they are beyond a diagnosis or a condition. And this is really coming from all the workshops that we have done in 2023 and 2024. And all the more than 500 people who participated in peer visits, have given responses to surveys, who have participated in workshops, in trainings, in round tables, and many levels of consultations. And based on which we have published our recommendations for equitable, diverse, and inclusive cancer care in Europe, and also a toolkit that we will be presenting to you later on. But here, the preference really was by those consulted, and especially those by lived experience, that we prefer person-first language. And this could also reflect that our world is within the cancer ecosystem, and those affected by cancer and those living with and beyond cancer. And here we feel that that a person first language reflects that people in our group are researchers, mechanics, teachers, electricians, etc., with cancer or living with cancer or with a disability, etc., rather than the other way around. But we do recognize that a choice of language should always be led by the individual that we are speaking to and the community that we engage with. So this is about language and a little background on what we'll be doing today. And with this, I would like to give over to Asako Asado, whom I know only for a very, very short period of time, but who will be sharing with us a very, very specific study that she has done. She will tell you more about who she is, where she's coming from, what's her background, and what she's ready to share with us about the experiences of people with autism.
Oh, thanks for the introduction. So my name is Asako Osedo. Can you see my screen right now?
Yes, you can.
Great. Okay. So I am an experienced designer and a researcher, and my work is mainly to investigate people's lived experiences and try redesigning the products, services, or the spaces to make the experiences better and more positive one. And recently, last year, I started my new research projects to understand neurodivergent individuals, especially with autistic adults and their lived experiences in community designs. And the community means it's such as work environment, school, hobbies, or institutional groups like this here, the Youth Cancer Europe, like that. So today, let me present about my research and the results of it. Okay, so before jumping into talk about my research in detail, let me explain a little bit about the neurodiversity. As it is described by Katie, in today's introduction, neurodiversity is the umbrella concept to understand the diversity of cognitive differences such as autism, ADHD, so many things. And some research says 15 to 20% of the population is neurodivergent. It's quite a big group, so it needs to be considered a worth topic to discuss. And actually, the neurodiversity is a really big umbrella concept. So the traits and conditions vary, so diverse from person to person. Even the same diagnosis is given. However, there's also a lot of overlaps in traits in each neurodiversity conditions. For example, one of the interesting overlapping condition is the spiky profile. This refers that neurodivergents often exhibit exceptional strength alongside challenges in others, or like that. So what is different from neurotypical people is that neurotypical people commonly shows relatively consistent skills across different abilities. However, neurodivergents may have spiky profiles. For example, if someone is really good at logical thinking and possess fabulous writing skills or something, but at the same time, the person might be terrible at the remembering daily tasks or the being punctual like that. So again, each trait should be varied in each person. So it doesn't mean many neurodivergent people are good at logical thinking. It's that what they are strong at and what they're weak at is very varied indeed in each people. But it is more likely neurodivergents have spiky profile comparing to neurotypical people. And historically, fields in medicine or academic research highly focused on what they are weak at only. But it is clear that we also need to see what the person is good at too. However, in current society, it's unfortunate. Our society is usually designed for neurotypical dominant groups, and people tend to expect others to have average or consistent skills like neurotypical people. So the society put a lot of challenges on neurodivergent individuals. Then the hardship to navigate themselves in neurotypical dominant world, impacting the mental health of a lot of neurodivergent individuals. Neurodivergents report much higher stresses and social anxieties than general population. And the stresses here are varied, but for example, they may feel constant pressure to conform neurotypical norms, like hide their weaknesses or hide their neurodivergent traits and try pretending like neurotypical behaviors. So denying identity is much stress they feel. And then, for example, the people who have the hypersensory or hyposensory sensitivities are easily exposed to heightened stresses under the less sensitive environments like the noisy place or lights or smells or that type of stimuli will be the huge stress for them. So there are many stresses, but these are the very common things. And it's leading to the mental health issues. And especially for autistic adults, there are 3 times higher suicidal attempts rate we have. So in these types of high stress environments, it is clear that they cannot fully demonstrate their true abilities or freely enjoy their surroundings because they are exposed to the high stress. So according to this background, I set my research aim like this. So my research topic is like to understand the needs for community design that empowers autistic adults to navigate their lives authentically and positively in communities. And I focused on autistic adults in my research because I needed to narrow my research scope to be feasible to research. But as I mentioned about the overlaps, the common overlaps, I tried to identify the themes, the which seems relative to broader population, not only for autistic adults. So to seek this research aim, what I did, the research method of mine was very simple. I talked to autistic adults. So to investigate the lived experience of autistic individuals, I used several of the design research methods, uh, like these photos, and did a participatory design research with 10 autistic adults, and I also participated the 3 online autistic communities to keep discussion about and learn about their journey and experiences in different community settings, such as schools or workplace or the hobby group or the other organizational or private groups. And then after this research, this is with the summary of results, what I found through my research. So first is this is the overarching concept. I named it autonomous energy management. The autonomous energy management refers how it's important to allow neurodivergents to control their stresses and energy levels by themselves according to their own needs. And the second here is it is what I identified for critical conditions to achieve the concept of the autonomous energy management. So this is the recommendations for neurodiversity inclusive communities. Let me explain in detail of each topics here. So first, overarching concept of autonomous energy management. This is a fundamental concept of needs on energy management. So first of all, to enjoy community experiences, everybody need enough energy to engage to it. So it's obvious. However, the depletion of energy is a common problem to neurodivergence. This is not only for neurodivergence, but it is mentioned in the broader disabled communities or people with chronic ills, and I believe too with the people with cancers too. The right this visualization is I named it energy bathtub visualization. So the conceptualization of this idea. So the cube here is this describes each person's capability of energy, capacity of energy, sorry. And this from top, this is a stress inflow. People feel stresses in the environment, and the stress is stored, and they consume the energy capacity. And then if the water gets full and overload, and then maybe people get meltdown, or at least they need to give up participating in the communities at all because they don't have enough energy left. But with this concept, the very important part is this drain. So I called it a restorable mechanism. So energy is restorable by, for example, by taking break or being in engageable and comfortable place that neurodivergents feel less stress, and then they can keep as much energy left to use. And if they can have a space here, if they can reserve as much energy as they can, then they can use the rest of energy to something they want to do. For example, having fun or socialize or like that. So this is a very basic concept. So the community design should be let people to manage their energy by their needs. So this is the 4 key conditions to allow positive energy management in community design. Let me explain from first. This first is the escapability. Escapability is the allowing freedom to take breaks or step away from activities or environments when needed. This is very simple, but super strong. One of my research participants told me that he was in a whole day work event and he was so exhausted in the middle of the day. If it's usual, he just give up, continue participating, and they skip the socializing part of the dinner or something. But one day he thought, maybe I can go back to hotel and take a 15 minutes break in dark room or something. And he did that. And he realized it's so powerful. He feels the energy restored and he could come back to the community environment. So allowing them stepping away without feeling judged or disevaluated, and it's feel free to go out and come back anytime. It's highly possible. The possibility of they can keep continuing participation might increase. This is the escapability, sorry. And second is the engageability. This is the creating enjoyable environments that make social participation meaningful and worth participating. So this is about stigma. When we think about autistic individuals, there's a strong stigma that, oh, they don't like socializing, or oh, we need to quiet and less stimulus environments for their special needs or like that. But it's not like that. Everybody needs to connect with others and everybody are willing to spend meaningful time. It's same with autistic adults. But joining community itself is very, very tiring. So if the experiences are boring or highly stressful, it's very easily for autistic people to give up participating because it's not worth using their precious energy. Maybe doing a house chore is more important or something. So here, the comfortableness and the enjoyability of the environment is highly important. And third is the adaptive prospect. I think this was a very interesting finding to me. First, it is common traits that autistic people don't prefer uncertain situations or sudden changes or like that. And especially for those who have challenges on executive functions, it is a common trait in the whole neurodiversity condition. It is hard to not seeing the goal or tasks or the community activities. It heightens the social anxiety. So community should show the clear instructions of showing what's happening next or what is the purpose, how we proceed these activities, the types of things should be stated clearly. However, it's interesting that it is also highly important that all processes are flexible and modifiable because almost all of my autistic participants in my research told me that they hate the rigid environments and that they need the freedom to change things. And they feel in the rigid spaces, they cannot use their strength or being authentic. One of my participants told me that when he work alone, he can use all of his creativity to create a new deliverables and he can use his hyper focused talents to make something new. But if he works in a community settings with team of the highly population of neurotypical people, there are frameworks to follow and he cannot change the framework or something. And then he said, I need to kill all of my creativity to work with them. So this is happening in the community settings that people are not fully embracing their talents in a rigid environment or the processes. So the balance of certainty and flexibility is needed here. Fourth, the last one is receptivity. This refers to an open and accepting culture that respects diverse needs. And the very important part is with sufficient knowledge about neurodiversity. Majority of my research participants mentioned that how others are knowledgeable about neurodiversity impacts their behavior of disclosing their autistic identity or autistic traits. When they feel safe and respected, they can behave more authentically because they are not being judged or being disevaluated with autism conditions. But in contrast, some of the participants also mentioned that they don't talk about their autism even with their own parents or families because of their lack of knowledge. So if they don't feel safe, they cannot behave authentically like that. So this was a summary of the results of the research. And then maybe I'm running out of my time, so I will finish here. But I hope these recommendations might inform community design to be more neurodiverse inclusive. Thank you.
Thank you so much, Asako. This was indeed very interesting. And obviously, I see all the hearts coming from our participants, so they did find it intriguing and interesting. Thank you so much, and good luck for the rest of the work that you will be doing with your study. Please don't go anywhere. Stay here with us as we will welcome to the panel Erik Storesson. Erik is from Sweden. Erik is a patient advocate with Youth Cancer Europe and has lived experience. He will tell us more about that. I would also like to welcome Lizzie amongst us. Lizzie is also going to share her lived experience. She is also a researcher and a patient advocate with the Symphony of Us, a Belgian-based organization, and she, if I'm correct, she was also born and raised in Belgium, if not in the Netherlands. You will tell us more, Lizzie. And I would also like to ask Maria to join us, Dr. Maria Koznarovic. She is a medical oncologist and a pediatric oncology resident in the Cluj Oncology Institute in Romania. So welcome to our wonderful panelists. I'm going to stop sharing my screen so I see all of you. Thank you so much for joining today. First of all, I'm going to give the words to Lizzie and Erik. We've heard general background for me and a little bit about our work on EDI with Youth Cancer Europe and why we feel that neurodiversity is an important topic to include in our work. And I said in the beginning that we will be speaking about intersectionality later because we know that everyone's identity is many and several things, not just one. And we also covered that in that conversation about language. But when we spoke with you, you have so much experience, and obviously the part of your experience that we would really like to hear about is your cancer experience. What was it like to be diagnosed, and what was it like for you to engage with your healthcare providers, with the healthcare professionals, whether it's the individuals, the people, the personnel, the institution, or the system more broadly. How did it work for you? So maybe in order for us to understand a little bit more about your experience, it would be lovely to hear from, where you're coming from. Lizzie, can I put you on the spot first?
Of course.
Yeah, it was really, really enlightening for me to speak with you last week a little bit about this. I think it would be really lovely if you could share with the audience some of the ways that neurodiversity may have influenced your treatment, diagnosis, all of your experience with cancer.
Yeah, of course. So maybe a little background. I was born and raised in the Netherlands, so you were right. Yay. I was only partly diagnosed with neurodivergency before I got diagnosed with cancer. So I was also not completely aware of, for instance, the information that Asako shared. I think one of the things that struck me most that we also discussed before was the fact that at 15 years old, my neurodivergency was misdiagnosed as bipolar disorder. And at the time, I moved on from that, but I was becoming painfully aware of this when I was in the hospital. And I just got out of surgery and it hurt really, really bad. And after doing some very, on the spot tests for me, instead of diving deeper into my symptoms that were actually real, they brought a therapist to my bed because they thought that I might be in psychosis or something. Because it turned out that this misdiagnosing of bipolar disorder was very much still part of my medical file. And it also showed up in the future on many different occasions when I would have to go to different specialists of different parts of the hospital for maybe different kind of treatments or different kind of supports. And in talking to the practitioner, it would be a very normal conversation. And the moment they would start looking at my medical file, they would always comment, "Oh, but you're bipolar, you have a bipolar disorder." So that changes things. And then they would kind of go back over the conversation we had before and kind of fitting it into the context of this bipolar disorder, in a way invalidating my experience. Because even though I told them I was misdiagnosed, they still took that very seriously, which was very unfortunate because that made me feel very unseen. And I think also there were therefore many opportunities missed for me to have better support.
Yeah, you touched upon something very important because I know we also had a conversation about having a proper diagnosis, because a lot of people might suspect or think or know that they have some sort of neurodiversity, but sometimes getting a diagnosis is, one, overwhelming for people, and two, there is so much stigma attached to it that actually it stops them from seeking help or seeking diagnosis. So, there is something to be said about the amount of stigma that is attached to neurodiversity in a larger societal context. But as you said, also in the healthcare setting, you felt that sometimes maybe some of the things that you wanted to say were dismissed because they were like, oh, if you have a bipolar disorder, then maybe we need to reevaluate every word that you said and every sentence that you uttered. And that can be very scary for a person. So some people might not even seek any sort of diagnosis if they feel it will negatively affect their interaction with future healthcare experiences. That's actually, an alarming thing that I have heard from others before.
Yeah.
Go ahead, Lizzie.
No, that's definitely true, because even though I was misdiagnosed, I was later correctly diagnosed as well before getting the cancer treatment. And even though that correct neurodivergency diagnosis was in place, the focus was not on that. It was on the misdiagnosis. And even for that correct diagnosis, I also didn't receive any additional care. So that leads you to think, okay, what is even the benefit of having this diagnosis then, when there's a lot of stigma that comes from, your surroundings, society, and there's also this gap or this lack, essentially, of care that is being provided when you also do have this diagnosis.
Yeah, that's something very important that you shared. And I think we really should talk about benefits, as you said, and additional support and care, and how much is it in place in health institutions. And we will be asking Maria about that later on. But first, let's hear about Eric and about Eric's experience. You need to unmute yourself.
Okay, we're good. Yeah.
Perfect.
Yes. I mean, I've had a long history of mental health issues. It's been diagnosed depression, anxiety, PTSD, PTSS, and they're not wrong. I do have those issues, but it's not helped me entirely. It's not the full story. I do have more subtle issues, and the thing is, these all go together. Like I have a hard time dealing with tumultuous situations, lots of impressions, too many people in the room, things like that, which has meant, we often have to share rooms, for instance, at the hospital. I can't really do that, generally speaking. And combined with the fact that I do have PTSD that is caused by being at hospitals, this just it increases the complexity a little bit.
Yes.
And then you have the added complication that the psychiatric care in Sweden. I've said this so many times before, so I apologize for those I've already told the story to, but it took them 1.5 to 2 years to get me a psychiatrist in Sweden, and then another year or so to get a psychologist. And during this time, I didn't get much support. And this has made me very averse to psychiatric care. So I do avoid it. So for now, I only have 3 antidepressants and 3 psychological formal diagnoses, but yeah, these repeated issues, it's delayed diagnosis, and it's been an issue for a while. But learning about neurodivergency, it's helped me a lot. It has.
Right. So I remember speaking with you years ago, Eric, about learning differences. And
Yeah.
I know that even, that conversation, the way it came about, I understand how people are shy and worried about talking about it first. Like I need to have that relationship with you that I could discuss it with you. Um, because there is so much negativity attached to it, and even the wording of it, right? Is it a developmental disorder? Ouch. Is it a learning difference, or is it a learning disability? Again, ouch. But it's important to know how people process information. And here the emphasis is on processing information. So I know we were talking largely about health literacy, like how do people navigate their treatment? How do people navigate the healthcare system? How do they navigate their own engagement with the healthcare providers, the different consultants that they need to speak with, the corridors of these big institutions, the halls of the hospitals, and all of that. And how you are given information, how do you process that information? How do you ask questions? And when is it the point when you realize that, yes, having a cancer diagnosis is extremely overwhelming? So having acknowledging that it's a trauma and needing support because you're inevitably overwhelmed, and therefore processing any kind of new information will be difficult. But if that is paired also with learning differences, then it can be disastrous for an individual. And I know we were speaking about this, and you were sharing how sometimes you felt like you were unable to ask more questions because people were treating you as you were dumb. And actually, I do know you. You're a very intelligent person. You have different jobs. You're also working in Youth Cancer Europe. You have different roles. You contribute. You're a very, very valuable member of society. And the fact that I even need to say this feels so shameful. So can you tell us a little bit about this? Because I think you're not alone with this. I think other people might, and I see Lizzie also nodding that other people might also feel like if you have a different way of learning, or you have a learning difference, or, as sometimes it may be coined a developmental or learning difficulty, then how will you be helped?
Yeah, I mean, so for me, it means I need to be able to ask questions without being judged. And sometimes it can seem like I'm asking questions to be confrontational, but I'm just asking questions not because I want to argue, but because I want to know why. But being able to ask questions and not being pushed or stressed by the individual, because sometimes they want you to understand because they say this, but they have to say in another way, and they don't have time for that, or they feel like they already gave you a good answer, so they shouldn't have to explain it again. So having that time, I think is very important, but it's also important to realize that you might need a different form of media. Maybe you need some visuals. Maybe you need it in a calm environment. Like you have to step away from the doctor-patient sort of situation and just talk in a way. And I know that's difficult in a medical setting, to be fair, because the doctors are already under time pressure. But it can be a stressful situation because they expect you to react in a way, or respond or have a question. I don't know. It's difficult to define exactly.
Thank you so much. So before we go to Maria, let's just think about some of the examples that you have brought up before. Like you said, once you mentioned that bright lights really trigger, and you were unable to think straight or to process information, and that just having like a quiet zone or a darker area really helped. Or wishful thinking, and this is something that came up during our workshops, that seeing pictograms, as in like pictures, or explaining things in play language, and having information maybe in a written form, not only just spoken words. These are some things that can help. But maybe, Lizzie, back to you. Do you think that there are some things that could have really helped in your engagement with the healthcare system?
Yeah, for sure. I, like Eric as well, I've developed a specific trauma around just existing in a hospital sensory wise. Like the lights are very bright, there are people around, you don't have much privacy, and you also don't have really the time that you need to process something as heavy as a diagnosis or maybe a second diagnosis, etc. For me, I think it would have really helped, just the first step being if somebody said, hey, we see you cry every time in the waiting room, is there maybe something that we can do for you? Or just check in already right after the diagnosis. Because, okay, I was not partly aware of the full diagnosis that I had, but I still had needs. They're not contingent on having a diagnosis. So just somebody actively reaching out to me to ask me about my experience would have really helped, because part of having this neurodivergency is also that I, especially in those crisis times, let's say, I'm not very aware of the immediate needs that I have. I'm just completely overwhelmed. So the first step would be somebody kind of privy to this, asking me what is happening and what I need. And for instance, like was mentioned before as well, just a quiet space, maybe after or before even a difficult conversation to have, maybe some extra time afterwards would have helped, like after a day or two of processing, to have a quick phone call about things in a private setting. For me, thankfully, this happened after a while. I forgot to draw blood every time before a scan, for instance. And my hospital started calling me every week beforehand to make sure that did I already draw the blood? Was I aware that I should be doing these things? So it can be in these little things maybe already, but just it starts with the feeling of knowing that a healthcare practitioner cares about your experience, maybe even beyond labels, and works with you to come to an understanding of your needs and what is available from the hospital.
Thank you. So I know that in some countries, people with, and again, this could be, interpreted as a derogatory term with special needs, might be assigned a navigator, which might be helpful or not. But in some other countries, this might sound like, science fiction and a wish list. And I think a lot of the things that maybe you have mentioned could have helped might actually sound like a wish list. So to hear about the reality of a person actually working in a clinical setting, I would really like to invite Dr. Kozmarovic Maria to tell us a little bit about, what is your background? How were you prepared in medical school to work with neurodiverse individuals before coming to work at the oncology center where you work today?
Hi. So, as Katie said, I'm Maria. I work in the Cluj Oncology Institute, and within my 12 years of medical training, the discussion on neurodivergence has been close to zero. When I did my university training, again, it started 12 years ago, neurodivergence was not nearly as much of a hot topic as it is today. However, we had two subjects in university where someone might have wanted to teach us something about neurodivergence. One of them was obviously psychiatry. We had adult psychiatry and pediatric psychiatry. They taught us the main psychiatric disorders about alcohol addiction, drug addiction, schizophrenia, bipolar disorder. They taught us how to recognize these diseases, a little bit about the treatment. However, nothing about the way we should communicate with someone with a serious mental health issue, and even less about the way we should communicate with someone who's neurodivergent. What we learned about autism was maybe a half an hour course where they put autism and ADHD into a single course, and they showed us two patients. This child has autism, this child has ADHD. Unless you become a pediatric psychiatrist, you won't need to know this. Now we're moving on to other diseases. We had two questions in our psychiatric exam about these diseases, and they sounded something close to, are you going to treat these diseases if you're not a trained psychiatrist? And the answer was no to both of these questions. So there was not much that we learned. When I started university 12 years ago, they decided to introduce this very new topic. I think it was an optional course, but I'm not sure. It was called something like patient-doctor communication skills, something like that. And I was very excited to join that optional course. I had been to many of Katie's workshops back then, and I thought it would be something very interesting. It wasn't. We were taught how to speak to three categories of patients: children, adults, and the elderly. And this was it. They did not say anything about talking to any other kind of patient, not to pregnant women, not to disabled people, not to any other kind of patient. And the exam was a joke. It was 1 credit. Everybody passed. Later on, during my residency, so I did 5 years of medical oncology residency, where I worked with adult patients. 90% of them, I would say they were elderly patients. And as you may know, in Romania, mental health is an extremely stigmatized topic, especially among older patients. And not many of them were open to talk about anything other than strict disease topics. When does the treatment start? When does it end? What do I need to do? they would not want to talk about anything else. The number of patients was so large that we couldn't offer this kind of support to everybody. However, should anybody want to discuss this topic, we were open, at least as the younger doctors. I would say that maybe less than 5% of the adult patients whom I treated wanted to talk about their mental health or wanted to reach out to a mental health specialist, such as a psychologist or a psychiatrist. We have 3 dedicated psychiatrists in the adult oncology wards, and we have 2 in the pediatric. One of them is hired by the hospital. The other one is Diana from Little People, whom you may know. But again, the patients needed to be convinced to talk to a psychologist. In Romania, I think the stigma around mental health is so great that people think if you talk to a psychologist, you're automatically crazy. And they did not want to have that sort of stigma attached to them. Now, after starting my second residency in pediatric oncology, things are a little bit different. And I wish to share with you 2 very different experiences with 2 different patients shortly. I know I only have a short time. So one of them is he actually turned 19, a 19-year-old patient. He started treatment when he was still a child. He's diagnosed with neurofibromatosis type 1, a kind of glioma, ADHD, autism, obesity, and other cardiac issues, which are not important. He is receiving a treatment that consists of oral medication. He needs to take it daily. And this kind of oral medication gives you the option to prescribe it to your patient once a month, every 2 months, or every 3 months. He's an extremely anxious patient. He comes to treatment with his mother. His mother is his caregiver. And we chose to only call him in every 3 months because the simple act of coming to the hospital is extremely, extremely stressful for him. As many of the lab tests that we can do, we do them at his home. We have a nurse go to his home. We keep in close contact with his general physician. We keep in close contact with his general physician. He's a very open doctor. We exchange lab results and other exams. He does home calls. We also keep in close contact with his mother through email and through the phone. And we provide a special kind of time off for the mother. We had to do a special request to the insurance company to give her the same kind of time off that a child's mother would receive, because in Romania only the parents of children are allowed as much time off, and he's already an adult. And unfortunately, we don't have a system put in where a caregiver can, you understand. So this is what we do for this patient. I would say that this is the best kind of patient because he's already diagnosed. He has his own psychiatrist. He has his own psychologist. We keep in contact with them. We get reports from them every 2 or 3 months. He talks with them weekly or monthly or however often he needs. The second kind of patient is the kind who gets diagnosed with a type of neurodivergency after his oncological diagnosis. Whether this is a result of the disease, especially in patients with brain tumors, or a result of the treatment, such as the surgery for a brain tumor maybe. If they start having this issue in the hospital, things are a lot more difficult. And I want to tell you about the second patient. He's a 15-year-old boy. He's still a minor, as you noticed. He has a sarcoma. His treatment is extremely aggressive. He's a native Hungarian speaker. None of the doctors speak Hungarian. At first, when he came, we thought that the only barrier between us was the language barrier. And the father said that he's an extremely shy child. He doesn't like speaking to people. He would always speak for him, translate for him. And it took us a couple of months to realize that it was not only the language barrier that was between us, there was something else there. Our psychologists, the hired psychology and Diana, both worked with him, again, through a translator. And after a couple of months, we came to the conclusion that we need to bring in a psychiatrist because there's more there than just the language barrier. His blood counts were extremely low when this happened. We needed to prepare him for radiotherapy. You may know that in radiotherapy, you need very good communication with the patient. He needs to stand completely still for maybe at least 15 minutes. And this was not possible because he would not respond to us. He was not a dumb child. His room was right across from our room. We could hear him speak with his English teacher online. He had online classes, and he was fluent in English. I could see his math textbooks. He was doing advanced math. He was great at it. So it was obvious he was not a dumb child. It was just this communication problem. So a couple of weeks later, the psychiatrist came. He was a very young psychiatrist because the patient's blood counts were very low. He had 20 minutes to talk to the patient and diagnose him and give us a proper therapeutic option so that we could collaborate for the radiation therapy. That was the reason. And he talked to the child with a translator. He came out and he said, "There's nothing wrong with him. He's normal. You don't need to treat him. Give him a sedative if you want to do the radiation." And that was it. It stopped there, which is exactly what we did because the radiation started a week later and there was nothing else we could have done.
Mm-hmm.
And all of us, we felt that this was not enough because we knew there was something wrong there. We cannot put our finger on it. We still can't communicate with him properly. And he's an extremely intelligent child. Later on, the father told us that he had seen many psychiatrists in the past. He did not wish to tell us this when he first came. And they all told him that he was fine. He was completely fine. There was nothing wrong with him. So
you kind of pinpointed something that actually developmental differences might not be easily diagnosed, also might not be acknowledged as real problems. In the first, when we talked at the beginning, you also mentioned something about mental health being dismissed a lot culturally in some countries. And that's one subject, but then neurodiversity and information processing or developmental difference is sort of like a separate issue from mental health.
I think it's not even a topic.
But it's not a topic, but it's not recognized as a thing, right?
If mental health is stigmatized, neurodivergency is not even talked about.
Yes.
So
yes. Yes, thank you so much, Maria. I've seen people reacting. I don't see anyone writing anything in the chat, but I do see the reactions. I think it was extremely informative. So we do find ourselves with people's lived experiences being very complex, difficult. We do have a problem with labeling, whether it's helpful or actually not helpful, because if the system is not providing support, then it can just further stigmatize. But on the other hand, in the lack or in the vacuum of proper diagnoses or a developed framework on how to approach and how to engage with individuals, the healthcare providers are really unable to find systematic and strategic approaches. Having said that, I think we're all very impressed by the personal care that your patients have received. Everybody's nodding on the panel. So we would love all healthcare providers to be disinvested. And we do know that a lot of them are, but the kind of like the system is stacked against you, right? Like you were not prepared for it in medical school. And I don't know how much, safeguarding or strategic policy framework is there available in the Oncology Institute, for example. Yeah, probably not a lot. Yeah, so we are kind of running out of time. I wanted to bring you back to this conversation again, but I might not be able to at this point, Asako, but I don't know if you have 1 or 2 sentences to reflect.
That's fine. It's very interesting. Stop this ongoing. So please keep discuss.
Thank you. So thank you, everyone. Please stay on the line in case we will be able to get back to you. And let me just share again. Yes, there we go. So I would like to now invite, I don't know if you will be able to see. I will have to stop sharing and start sharing again. In the meanwhile, I would like to say that I will invite Carmen Monke to come and share with us some of the work that we have done and some of the recommendations that I'm not able to press slideshow or advance my slides. I might need somebody else to share
Let me.
slides. I'm really sorry, my computer doesn't allow me. So as a little background, as I said, in 2023 and in 2024, Youth Cancer Europe within the EU-CAYAS-NET European co-funded project have undergone quite a large body of work, doing systematic reviews, scoping review of literature, grey literature and academic literature, field visits and peer visits to 5 different hospitals. When you're ready, Carmen, please go ahead and share. In the meanwhile, I just give the background. And have had roundtables and several consultations before publishing some of the work that we will be sharing with you. And
Yeah.
there you go. So I'll give the word over to Carmen, who also has lived experience and has been leading a lot of our work on this research topic.
Thank you, Katie, and hello, everyone. I'm Carmen Monge. As Katie says, I work as a researcher and patient advocate for Youth Cancer Europe, and I'm very happy to introduce to you the recommendations for equitable, diverse, and inclusive cancer care in Europe. So this was published last year in the European Parliament, and it is available in 8 languages. So if you want to check them out, there is the link. We came out with 3 main recommendations, and it's basically to improve the research by improving the data collection and also to diversify research teams. As we already mentioned a lot, is that we have to improve diversity and inclusion in cancer services. And lastly, we have to improve those same things in patient organizations. So this was a collaborative work. We did a lot of literature review. We also did 2 surveys, one for patients and one for healthcare providers. And lastly, we did a focus group with the key stakeholders in Europe. So from this, we came out with 10 target actions. And these ones are measurable, actionable, and actually everyone can do it. These 2 are the ones that are focused on neurodiversity. And basically what we want to make it happen is to improve the research on visible and invisible disabilities. We know by research that people with autism, they don't receive the same treatment or the right treatment during cancer, and that leads to worse outcomes after the treatments. So we have to do research on this. We also have to create accessibility policies and audit to support people with disabilities in the healthcare system, in the patient organizations, and on the research teams. For this, we need policies that support this population, and we need the opinion of the people of this community so they can promote more research and to give maybe advices to the people on the healthcare system so they can improve these conditions for them. Apart from this, last year we also launched the Train the Trainer Toolkit that is going to show not only healthcare providers how to be more inclusive, diverse, and equitable, but also to researchers and to patient organizations. Something very important that came from these courses is that we have to have an inclusive and accessible communication. So these are the top tips that I can extract from this toolkit. And basically, the first one is to be authentic, because authenticity builds trust. And this could be like the way that you behave with different people. Like, for example, the behavior, the eye contact, the body language that you give to other people can be interpreted differently depending on the person. So be authentic and be honest, but also be conscious about how do you behave with others. Another one is admit your mistakes. Nobody's perfect, right? So if you know that maybe there was some kind of misunderstanding or miscommunication, just ask for forgiveness and clarification as well. The other ones are quite easy, is to be self-reflective and be flexible. This means that if you know how you communicate, you can communicate with others just adapting to their style. So maybe you can offer, I don't know, written instructions or step-by-step, or maybe a summary. One of the comments is that maybe this webinar is quite long for neurodiverse people, but luckily this is being recorded, so maybe other people can see it after and stop and adjust to their necessities. Lastly, we have to consider a range of needs. And with this one, I go back that we have to ask the person like what works best for them. This could means that maybe they need people to repeat things to them, or they need maybe more space as well. Or the last one is to press pause. So if you think that there is a little bit of miscommunication, just stop and start thinking about that. Maybe they need more time, or maybe you need more time to adjust the way that you communicate. So don't be afraid to reflect on yourself, ask for advice, press pause, and lastly, to ask for forgiveness if there was a miscommunication. So if you want to know more about this, we have resources for you. You can see the toolkit, you can see the recommendations as well. My colleagues are going to put the links about all this, but I want to introduce the video that Eric shares his experience with this. We also have a glossary of neurodiversity terms. And lastly, a podcast of neurodiversity in the workplace that maybe could be useful for everyone, not only for this community, but for everyone. So now I'm back to Katie, so she can explain a little bit about the planned projects in the future. Thank you.
Thank you so much, Carmen. So as we said, there was a lot of work done already, and we do feel that both the recommendations, white paper, as well as a trainer toolkit that was really meant for healthcare providers, but also for for researchers and academics, and also there was special focus on building inclusive patient communities, that all of these tools we believe are really helpful and contain a lot of the reflection from hundreds of people with lived experience within our communities, which we feel very good about. And we feel that there is a lot of good tips and ideas were shared and published, but we do know that there is a lot more to be done. Within the next 3 years, we have a few things in the works. We are still yet to have final confirmation on starting these projects, but we thought it would be good to share what's in the works. And one of the things is creating an inclusivity checklist and certification system for healthcare institutions. This is a huge undertaking. So I know we talked about healthcare systems and hospitals having sort of like an EDI audit, but we feel it's too big. It's a really, really big and overwhelming thing. So when we were talking with different stakeholders in our consortium, we felt that starting with an inclusivity checklist and providing training on how to use this checklist and achieve progress in fulfilling more and more requirements within an individual hospital or clinic or healthcare institution would be really helpful. And as a motivation, we should actually create a certification system for these healthcare institutions on their inclusivity. And we will be, if we do get the funding, we will be rolling this out Europe-wide, and we will be starting it with 10 hospitals in 10 European countries. And we have the support from major medical societies and the European Nursing Society. So we feel this could be a super big milestone. And at the same time, we will also create a self-assessment checklist for patient communities with tips and tricks on how to make communities more inclusive and easier for diverse individuals to engage with, including with for people with neurodiversity. And we will be working on guidelines for inclusive events for people affected by cancer. And I think these are all very relevant and important, at least for us and within our work, because we do organize a lot of events and we do build a lot of communities and we do engage with healthcare systems. So if we want all of these to be more inclusive, then this is sort of like our step forward. And we wanted to discuss today as well, I don't know if you can advance the next slide. We just wanted to close this conversation on what baby steps could be taken to make a difference today, even if we disregard the big 3-year plan that we devised. So if you take the slides down and you stop sharing your screen, Carmen, thank you so much. Then it would be lovely to see all of our panelists together, and just to ask if anyone has any final words before we conclude this webinar on some baby steps going forward. And I'm going to put Maria on the spotlight. If you could just do one thing, what would that be?
Oh God, just one. I had a list of like 6 things. Okay.
Oh, you did? Okay, go on. Say one, and then we'll see if maybe the rest of the 5 will be mentioned by others. And I will ask the same from everyone.
I will say the most important one, not the first one that I would do. I would do a course in the university about neurodivergence. Because apart from the patients, I think that many of us doctors are neurodivergent.
Yes.
And I think that this course would change lives for doctors and patients.
Amazing. We're putting it down. as a to-do. Amazing, really, really good. Asako, because I didn't hear from you for a while. You need to unmute yourself.
Hello. Sorry, is that the question? Is the what we can make the difference
Yes.
for medical systems?
For all of our experiences, for everyone, well, very specifically with every cancer patient with neurodiversity to have a better experience and a best chance of getting better.
Yeah, as I presented for 15 minutes, I have so many ideas, I think. But every organization and process, what I think is we need to think about take more time to people get relaxed and to be understood. I think all of the processes are so in rush in recent society, and the people need to be go forward and straight, and the things should be efficient or something. But if we have more time to get to know each other, if we have more time to relax and they think about it, and then I think the diversity and inclusion increase a lot only with the accepting inefficiency and taking time. So this is
Thank you.
Yeah.
Wonderful. Thank you so, so much, Asako. Eric?
One thing that's difficult, something concrete, something not concrete, awareness, and then actually implementing changes and taking time in the hospital setting, giving the doctors time. And I think it's fair to say that we have to give the doctors time as well. We can't just say you need to give us more time because they don't have much, but to actually give them the tools in the medical setting.
Thank you, Lizzie, and then we will close it, Carmen.
Yeah, I think I've said it, and I think it's been said, to kind of focus on the patient themselves and validating their needs for whatever they may arise from. And I think what Dr. Maria said as well, it's very important to educate ourselves, not only as healthcare practitioners, but also as just human beings, like she said as well, maybe more people have these conditions, and it would all benefit us and everybody to learn more as well.
Thank you. And Carmen, any words of wisdom?
Well, I think everyone says everything that I was thinking, but yeah, basically sharing is caring. The more that we talk about this, the more that we lose the stigma around it. And to think that it's not something that bad, and it's not bad actually. So to start talking about it, we realize that actually the community is bigger than we thought, and that we should understand each other better if we talk more about it.
Good. Perfect. Thank you so, so much. So everyone, thank you so, so much for staying with us on this webinar. It was 90 minutes, so it is a long one, but it is a very, very big subject. And I think we just touched a bit on the subject, but do stay tuned, because we will complete a series of webinars on diversity and inclusion, and this was just one. A very, very technical apology. Our chat was disabled. I only found out now in the last 10 minutes. So we apologize from all of the participants who wanted to share things but couldn't, because our chat was not working. But you will see some important and good references in the chat right now that was shared with everyone. And thank you so much. See you soon. Stay tuned. Follow us on social media, follow the project, and an amazing big warm thank you to Asako for being with us, for Eric and Lizzie for sharing their stories, for Maria sharing your perspective from the medical point of view, and for Carmen for sharing our research and our publications. Thank you, everyone. It was an amazing evening. See you soon. Stay.
you.
Bye.
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 Bye.